When you usually walk into a medical clinic or a wellness center for a treatment, there is a very specific expectation of how things work.
Right. You expect the doctor to, I don't know, reach into a sterile cabinet and pull out something pre-made.
Exactly. Like they pull out a synthesized medication and administer it. It's a completely external fix. But today, we are flipping that entire script.
Hmm.
Because today, medicine is you.
It really is. We are moving entirely away from, standardized synthetic interventions. We are stepping right into the frontier of autologous regenerative medicine.
Autologous.
Yeah, autologous simply means it comes strictly from your own body. So there are no foreign substances, no mass-produced chemicals. It's literally your own biology just being repurposed.
Which is wild to think about. And for this deep dive, we've gathered a massive stack of medical reviews, aesthetic clinic brochures, and highly specific procedural guidelines.
We really went through it all.
We did. Because we want to demystify a highly discussed but rarely detailed procedure in women's sexual health, which is the O shot, or the orgasm shot.
Yeah, the mechanics of it are just fascinating.
And that's our mission today. The focus is strictly logistical and procedural. So for you, the curious learner listening right now, we are going to map out what exactly happens during one of these appointments.
From start to finish.
Right. How a patient prepares for it, what happens in the room with the blood-spinning centrifuges, and, the biological mechanics of why it works.
And understanding those biological mechanics is so crucial because, looking at this strictly through the lens of regenerative medicine, it really removes the mystery.
And the stigma, right?
Exactly. The cultural noise and the stigma that usually surrounds intimate health just sort of falls away. We're talking about utilizing the body's own natural healing cascades in a highly localized, targeted way.
So the most surprising thing I found while looking through these procedural guidelines is that the appointment does not actually begin in the waiting room.
Oh, not at all.
There are these silent preparation rules, like things the patient absolutely must do and absolutely avoid days before they ever step foot in the clinic.
Yeah, the prep is almost as important as the procedure itself, because this treatment is a platelet-rich plasma, or PRP, injection, so it relies entirely on the patient's own blood chemistry.
Right.
And if the patient's blood is chemically compromised, the treatment fails before the clinician even picks up a syringe.
Okay, let's unpack this. Because it's basically like baking a highly complex cake. If your base ingredients, your blood, are chemically altered by an Advil, the whole recipe falls flat.
That is a perfect way to put it.
But I want to push you on that. Why exactly does a simple Advil ruin the process? Because the most prominent restriction I saw across all the clinical protocols is the absolute prohibition of NSAIDs for 5 to 7 days prior.
Yeah, non-steroidal anti-inflammatory drugs. So no aspirin, no ibuprofen, no naproxen.
Right, but why? Is it just a general suggestion to avoid bleeding?
What's fascinating here is the actual mechanism. NSAIDs work by chemically deactivating platelets. They do that to reduce inflammation throughout your body.
Okay.
But for the O shot, activated platelets are the fundamental building blocks of the entire treatment. So if you deactivate them with a simple headache pill, you stop those platelets from releasing the crucial growth factors we're trying to harvest.
You are essentially putting the construction workers of your blood to sleep.
Exactly. And we need those construction workers alert and active. Specifically, we need them to release VEGF, which is vascular endothelial growth factor, and PDGF, platelet-derived growth factor.
That sounds like a mouthful, but they're basically instruction manuals, right?
Yeah, they are the proteins that actually instruct the surrounding tissue to start regenerating, to build new collagen, to form new blood vessels. If your platelets are chemically stunned by an NSAID, they just will not release those factors when they get injected.
Wow. And the restrictions get even more granular. When you look at the dietary and lifestyle protocols, patients have to stop taking fish oils, St. John's wort, ginkgo biloba.
Vitamin E as well.
Right, vitamin E, all in the days leading up to the appointment to prevent excessive bruising. But I was genuinely shocked by the day of dietary prep.
The fasting rules are pretty intense.
They really are. It is not just showing up. Patients have to adhere to a strict, no-fat diet for 12 hours beforehand. And then they undergo a complete fast for 4 hours prior.
Yeah, and that fasting protocol, specifically the restriction on fats, is all about the physical quality of the blood plasma.
How so?
Well, when you consume a heavy, high-fat meal, your blood can actually become lipemic. This means there is a really high concentration of lipids, fat droplets, just circulating in your bloodstream.
Which turns the blood plasma cloudy, right? I read it gets almost opaque.
It turns into this milky, viscous substance. And when the clinic tries to process that blood in the centrifuge, those circulating fats completely interfere with the separation of the platelets.
Oh, so the machine can't sort it properly.
Exactly. You end up with a much lower yield of the growth factors you need. Plus, the injection itself can become more inflammatory in a negative way. The clinical goal here is a perfectly clear, amber-colored plasma.
Liquid gold.
Right. And getting that requires a clean, fasted metabolic state.
And alongside the fasting, there is a massive emphasis on hydration. Like, the guidelines recommend drinking half your body weight in ounces of water daily leading up to the appointment.
Hydration is key.
And they heavily front-load water in the 2 hours before the blood draw. Getting that hydration right ensures you actually have a robust volume of blood plasma, right?
Yeah, it's the fluid medium required to suspend and then extract all those platelets.
Plus, the hygiene protocols are clearly mapped out too, like gentle washing and shaving of the pubic area prior to arrival to prep the canvas, so to speak.
Right. So once the internal chemistry and the external canvas are prepped, you go into the clinic and the biological engineering begins.
Now we're getting to the sci-fi part.
It really feels like it. The clinician draws a surprisingly small amount of blood from the patient's arm. We're talking usually just 10 to 30 milliliters.
That's barely anything.
Yeah, it feels absolutely no different than a standard diagnostic blood test.
But instead of sending it off to a lab, they take that vial and put it right into a centrifuge in the treatment room. I was looking at the actual clinical specs for these centrifuges, and they are pulling intense G-forces right there in the room.
They spin the blood at incredibly high speeds for about 5 to 15 minutes.
And the centrifugal force uses the physical density of the blood's components to separate them out, right?
Exactly. The blood naturally stratifies into 3 distinct layers inside the tube. At the very bottom, pushed all the way down by their heavy cellular weight, are the red blood cells.
Okay.
Then at the very top, you get the platelet-poor plasma. That's mostly just that clear fluid we mentioned earlier.
And sandwiched right in the middle, trapped between the red blood cells and the fluid, is the target. The highly concentrated, platelet-rich plasma, the PRP.
The liquid gold. Isolating that specific middle layer is the entire crux of the procedure.
See, here's where it gets really interesting. Because if you are listening to this and thinking about ever booking one of these appointments, this is perhaps the most critical thing to know. Not all centrifuges are created equal.
They definitely aren't.
Wait, so if it's just spinning blood, why do different clinics have different outcomes and, frankly, wildly different prices? Is it just branding?
It is absolutely not just branding. The precision of the medical technology cannot be overstated here. If a clinic is using a cheap, imprecise machine, it leaves red blood cells trapped in that middle plasma layer.
And you don't want those.
You really don't. Red blood cells cause oxidation and unnecessary inflammation when they're injected into soft tissue. They actively hinder the tissue regeneration we are trying to achieve.
So you aren't getting liquid gold, you are just getting an inflammatory injection.
Precisely. High-end clinics utilize specific medical-grade systems that are designed to eliminate those red blood cells entirely.
Yeah, the clinical brochures frequently highlight the EMSITE Pure PRP system, for example, which operates as a completely closed, sterile system and removes 99% of those red blood cells.
That one is very common in top-tier clinics.
But then there are other clinics utilizing the Selfel system, which seems to take a different biological approach altogether.
What's fascinating here is that Selfel is a major variation. Instead of just creating a liquid plasma, it converts the PRP into a platelet-rich fibrin matrix, or a PRFM.
The matrix.
Yeah, by adding a specific calcium compound during the spin, it forces the plasma to form a physical gel. It creates a biological scaffold.
Wow. So it basically traps the platelets in a web.
It protects them. In a standard liquid PRP injection, the platelets tend to just dump all their growth factors into the tissue at once, and the fluid dissipates rather quickly.
Okay, I see.
But the PRFM scaffold holds the platelets in place. It allows them to release their VEGF and PDGF in a slow, sustained manner over several days. Many clinicians argue this leads to much more robust tissue remodeling.
But even with the standard liquid PRP, there is an activation step right at the end, right? I read that literally seconds before they inject the plasma, the clinician will draw up a tiny drop of calcium chloride or thrombin into the syringe.
Yeah, that's crucial. They're artificially triggering the platelets to wake up. They want them to begin their regenerative cascade before they even hit the tissue.
It's like turning the key in the ignition.
Exactly. It simulates the biological signal of an injury. Inside your body, platelets just float around passively until they encounter the calcium released by damaged blood vessels.
Ah, so the calcium is the alarm bell.
Right. So by introducing calcium chloride in the syringe, the clinician mimics that damage signal. It ensures the platelets are fully active and immediately ready to start building new tissue the absolute millisecond they are injected.
Okay, so we've got this perfectly isolated, hyper-concentrated vial of liquid gold. But getting it out of the arm is the easy part. I have to ask what everyone is thinking we are talking about needles in highly sensitive, deeply innervated genital areas.
The elephant in the room.
Right. How does a topical cream truly mitigate that reality? How do you get it back into some of the most sensitive mucosal tissue on the human body without causing agony?
It's a fair question. And the pain management protocols are actually the primary focus of the initial consultation, as they should be. It requires a layered, multimodal approach.
So it's not just one thing.
No, the very first step is applying a pharmaceutical-grade topical anesthetic cream directly to the clitoris and the anterior vaginal wall. And then the patient simply waits.
And they wait a while, right?
It takes anywhere from 20 to 45 minutes for that cream to fully penetrate the mucosal barrier and numb the superficial nerve endings.
A 45-minute wait just for the topical numbing to set in, that really shows how seriously they have to treat the tissue sensitivity.
Absolutely. And
Yeah.
honestly, the topical cream is usually just the baseline. Most clinicians follow that up with a local lidocaine injection.
Like a shot at the dentist.
Very similar. They perform a clitoral block to numb the deeper tissue structures that the topical cream just cannot reach. Then, right before the PRP injection itself, they introduce temperature and kinetic distractions.
Distractions, like what?
They might apply an ice pack to the area or utilize a strong vibration device right next to the injection site.
Oh, I read about this. It's actually a neurological trick called the gate control theory of pain.
Yes, exactly.
Basically, your brain and spinal cord can only process so many physical sensations at once. So if you overwhelm the local nerves with a strong buzzing vibration or the intense shock of cold, it literally closes the neurological gate to the sharp, precise pain of the needle.
It's a brilliant hack.
The brain gets distracted by the vibration. It is the exact same reason you instinctively rub your toe after you stub it. You are flooding the area with touch signals to block the pain signals.
Exactly. So the layering of the topical cream, the deep lidocaine block, and the gate control theory via vibration, it means the actual physical intervention is incredibly tolerable.
What do patients usually rate the pain as?
Most patients rate the procedure as a 2 out of 10 on the pain scale. They describe it mostly as a feeling of deep pressure or just a brief momentary sting.
And the injection process itself only takes about 5 to 10 minutes, right?
Very quick.
And the practitioner is using an ultrafine needle to target two very specific sites. Let's talk about those. The first site is the clitoris, or the clitoral hood. The medical objective here is angiogenesis.
Right. Angiogenesis is the physiological process through which new blood vessels form from pre-existing vessels.
So they're building vascular roads.
Basically, yes.
Yeah.
By injecting the activated PRP directly into the clitoral structures, the concentrated growth factors force the tissue to rapidly build a denser network of capillaries.
And more blood vessels mean more blood flow.
It drastically increases vascular engorgement during arousal. It also stimulates the regeneration of the nerve endings themselves, which enhances overall sensitivity and tactile response.
The second injection site is the distal anterior vaginal wall, which is the region colloquially associated with the G-spot.
Yes.
And injecting PRP here serves a fascinating dual purpose. On the sexual function side, it aims to boost natural glandular lubrication and enhance internal arousal. But structurally, it is utilized as a treatment for stress urinary incontinence.
Which is such a huge issue for so many women. Stress incontinence is that mild leakage you might experience when coughing, laughing, sneezing, or exercising.
Right.
It happens because the pelvic floor, which is the muscular hammock that supports the bladder and the urethra, it weakens over time, often due to childbirth or hormonal changes.
So it just can't hold things shut.
Right, when physical pressure pushes down on the bladder, the weakened tissue cannot keep the urethra clamp shut.
And this is where the regenerative aspect creates a massive aha moment. The PRP is not just plumping the tissue like a filler, it is acting like biological mortar.
Biological mortar, I like that.
The growth factors stimulate massive collagen production in that anterior vaginal wall. It literally thickens and beefs up the structural tissue surrounding the urethra. So it rebuilds the integrity of the wall so that when you sneeze or jump,
Mhm.
the urethra actually has the rigid support it needs to stay closed.
It is utilizing cellular regeneration to solve a structural, mechanical failing of the pelvic floor. It's pretty amazing.
So the injections are finished, the needle is gone, and the entire physical appointment has taken maybe 40 to 60 minutes total.
Yep, you're done.
Zero clinical downtime. You get dressed and you can drive yourself home.
The deep numbness from the lidocaine block will wear off over the next few hours. And patients are told to expect mild spotting, maybe a bit of swelling, or this strange feeling of fullness in the tissue for up to 3 days.
But this is where I found a glaring contradiction in the clinical manuals regarding what happens when the patient goes home.
The post-care protocols.
Yes. So what does this all mean? Because if this is a medical procedure, why are some of the clinic guidelines explicitly stating that a patient can resume normal sexual activity within 4 hours of the appointment, but other manuals emphatically state the opposite, like demanding absolute abstinence from intercourse for 3 to, in some cases, 5 days?
It's a huge discrepancy.
Why is there such a massive difference for the exact same procedure?
Well, it goes back to the autologous nature of the treatment. We are not dealing with a manufactured pharmaceutical that has a uniform, rigid FDA instruction manual. We are dealing with biological matter.
Right.
And clinical protocols vary wildly based on a specific physician's training and their personal threshold for risk.
Yeah.
The doctors advocating for a 3 to 5 day waiting period are primarily concerned with two things: infection and diffusion.
Okay, let's break down the infection risk first. Because even though it is an ultrafine needle, it is still puncturing a mucosal barrier.
It creates microwounds. And the vaginal microbiome is very complex. Those tiny entry points are vulnerable. A cautious physician wants those needle tracks completely sealed and healed over.
Just to keep bacteria out.
Exactly, to prevent any external bacteria from being driven deep into the tissue during intercourse.
Makes total sense. And the diffusion issue.
Depending on the specific preparation of the PRP, particularly if they're using the thicker PRFM scaffold we discussed, the fluid can sometimes leave small, palpable bumps or blebs under the surface of the tissue as it integrates.
Oh, wow.
Yeah, so some clinicians worry that the intense friction and physical trauma of immediate sexual activity could massage or literally push that liquid gold away from the targeted nerve bundle.
Before it has time to work.
Right, before the growth factors have time to lock into the local cells.
I mean, you just spent a significant amount of money and underwent an invasive procedure to put those platelets in a highly specific millimeter of tissue. You do not want friction spreading them out into the surrounding area.
You are protecting the biological investment.
And the patient's role in protecting that investment continues for weeks. I saw that the procedural guides detail actual homework the patient has to do to maximize the success of the injection.
Homework. Yeah.
Many providers mandate the use of pelvic floor muscle stimulation devices, like the Apex M or the Intensity device. Patients are instructed to use these mechanical devices twice a day in the weeks following the shot.
Because the regenerative process requires mechanical signaling. When you introduce the PRP, you provide the raw materials and the instructions for growth.
But it needs a push.
Yes. Utilizing a pelvic floor stimulation device forces the newly forming blood vessels and collagen networks to develop robustly. The physical contraction and stimulation of the muscle tissue signals to the body that this area is active. It tells the body, hey, we require dense, strong cellular architecture here.
Which perfectly explains the timeline of the results. Because this is not an instant fix. You don't walk out of the clinic with regenerated tissue.
No, it is a biological growth cycle.
Right. Patients might feel initial changes within 3 to 7 days, often described as slight tingling, heightened awareness, or tiny pokes in the tissue as the nerve endings begin to wake up and respond to the growth factors.
But the true structural regeneration takes significant time. Collagen synthesis is not immediate. The peak results where the tissue has fully remodeled, the biological mortar is set, and the new vascular networks are actively functioning. Those typically form at 6 to 8 weeks.
And I read in some patients with slower metabolic responses, it can take up to 3 months to fully manifest.
They can. But once those structural changes peak, they are relatively long-lasting. The data suggests that benefits hold for 1 to 2 years before the natural aging process catches up and a maintenance shot might be required.
You are fundamentally turning back the biological clock for that specific quadrant of tissue.
It really highlights the incredible intersection of natural human biology and high-tech application. You are harnessing an innate healing cascade, concentrating it to a level the body could never achieve on its own, and delivering it with pinpoint accuracy.
It's amazing. I mean, you manage your diet, you banish the Advil, you fast to keep your blood clear. Then the clinic draws your blood, uses extreme centrifugal G-forces to isolate the exact cellular workers needed, layers on neurological pain blockers, and injects that activated serum to physically rebuild your nerves and pelvic floor structure.
It's a marvel. But detailing all of this, um, it leaves us with a rather profound regulatory puzzle to consider.
What do you mean?
Consider the sheer mechanical complexity of what we just discussed.
It's a lot.
Blood is being drawn.
Mm.
It is being mechanically separated via high-speed centrifugation. A clinician is drawing up complex nerve blocks and injecting modified human tissue deep into highly vascular, intimate mucosal areas.
Right.
But right now, in many places, this procedure is available in high-street aesthetic clinics. Sometimes they're operating in the room right next door to where someone is getting a standard facial or lip wax.
The accessibility is incredibly high. Anyone can just walk in.
But the regulatory bodies are catching up. The UK government, for example, is actively consulting on a comprehensive licensing scheme for non-surgical cosmetic procedures.
Oh, interesting.
Yeah. They are analyzing procedures exactly like this one to determine which treatments are so biologically complex or carry such high potential risks for infection and tissue damage that they must be legally restricted.
Restricted how?
Specifically, they are looking at restricting autologous procedures purely to regulated healthcare professionals operating under the strict hospital-grade oversight of the Care Quality Commission, or the CQC.
Wow. So as regenerative medicine leaves the hospital and enters the wellness clinic, the line between an accessible cosmetic tweak and a serious medical intervention is completely blurring.
It is the defining question for the future of autologous treatments.
Oh.
As we figure out how to extract, spin, and inject our own biology to cure everything from joint pain to sexual dysfunction, how will future regulations dictate who is legally allowed to handle your blood?
Right.
At what point does a high-street clinic become an unregulated surgical theater?
That is exactly the kind of question that changes how you view the entire industry. The medicine is you, but who should be trusted to administer you back to you?
That's a lot to think about.
It really is. And we want to thank you so much for joining us on this deep dive. Keep questioning the science, keep exploring the mechanics of your own health, and we will catch you on the next one.